This program is brought to you by Emory University.
Good morning. Thank you everyone for being here. As you can see, Bryan Kindya is our speaker today. Bryan is a second-year fellow in our clinical track, Duke University undergrad, Emory Medical School residency, and now fellowship. And he is going to talk to us today about management of pulmonary embolism. Bryan.
All right, thank you everyone for coming today. So I think pulmonary embolism is one of the things we see pretty commonly in the inpatient service and also kind of outpatient follow-up in clinic. And so with a lot of data coming out recently about how to handle pulmonary embolism, especially the higher risk ones and intermediate risk ones, it was good to kind of review and see where all that kind of comes from. So the objectives for today, we're going to kind of review management and the data behind using systemic lytics for massive and submassive PE. We'll review the management and data behind catheter-based therapies, both catheter-based lytics and mechanical thrombectomy with a recent Flair trial coming out. And then also, down the line, talk about some of the long-term complications or consequences of pulmonary embolism, namely CTEPH, in terms of its workup and management as well. No disclosures. So we'll start off with two cases, both of which I've seen in the last 6 months, one down at Grady and one at Midtown, who presented with kind of very similar PEs, but were managed subtly differently because of some different baseline characteristics. So the first is a 68-year-old male with a history of hypertension, diabetes, B-cell lymphoma, who just finished his chemo and radiation therapy 3 months ago, who came in with dyspnea on exertion and pre-syncope with just walking to his mailbox, which was a very new baseline for him that had been going on for about 3 days. He was normotensive. He actually had a heart rate of 87. He was satting fine on room air. His EKG showed sinus rhythm with no acute changes. His troponin was a little bit up at 0.11 and kind of hovered around there with a mildly elevated BNP at 205 and a creatinine of 1.3. He got a CTPE in the ER at Midtown. As we see here, he had a pretty proximal clot burden in both the right and the left pulmonary arteries, as well as this kind of almost saddle-looking component. It's hard to get all into one cut here, but going kind of across the left and right pulmonary arteries. So pretty proximal large clot burden. This led to an echo being done for him, and as we kind of see here in our focused right-sided shot in our apical 4 and a combination of that and the TRJ, he's got a pretty unhappy-looking RV. He's got that hyperkinetic RV apex with a very down-looking RV free wall, kind of consistent with a McConnell sign. And with his IVC being dilated and not moving a whole lot, his right-sided pressures were in the mid to upper 60s, essentially. So we got called about him, and then we'll talk about what we did for him a little bit later on after we talk about some of the data. So case number 2 is a little different. It's a 30-year-old female with a history of obesity and a recent motor vehicle collision 2 weeks ago. She was seen at AMC and had left pelvic and right toe fractures, and she came in with 2 days of shortness of breath and dyspnea that started all of a sudden, and she admitted that since her car crash, she had essentially been sedentary because of pain in her left pelvis. Her blood pressure was also normal on admission, but she was pretty tachycardic. Her heart rate was in the 130s, sinus. She was satting 95% on room air, which isn't horrible, but for an otherwise healthy 30-year-old, that's not normal. Her troponin, again, hovered at around 0.3, 0.32 with a BMP of 56, and she did have a little bit of an elevated lactate as well when she came in with a hemoglobin of 10.4. And her EKG showed sinus tachycardia with an S1Q3T3 pattern. So she got a CTPE kind of late one night down at Grady. As you see here, she has essentially a saddle pulmonary embolism, a very large clot burden, and most pronounced in the right pulmonary artery, right at the bifurcation into the 3 lobar arteries. And it also extends here into the left pulmonary artery, most pronounced in the left lower lobe as well, but the very large proximal clot burden heavy on the right. She got an echo, and her echo images were much more difficult to obtain, but you can appreciate here she also kind of has that unhappy-looking RV with a not great moving free wall with the apex doing some kind of motion as well, consistent with severe dysfunction, likely McConnell's kind of looking RV. So we'll take a step back and talk about pulmonary embolism, epidemiology, and risk. So the incidence of PE diagnosis has gone up pretty recently since the introduction of D-dimer in the 90s, suggesting that in the past we probably were underdiagnosing it a lot of times in patients. But the recent studies that I saw reported an incidence of it around 112 per 100,000 cases, so about 1 in 1,000 people each year. In the US, PE counts for about 100,000 deaths annually. However, because PE is a cause of sudden cardiac death where we don't always get the true diagnosis as to what went on, the actual number of how many deaths it causes is probably truly unknown. And 30-day and 1-year mortalities are reported at about 4% and 13% respectively, with the risk going up with age. And so when we think about PE, we kind of think about in terms of this kind of pyramid structure. The majority of the PEs that we see on the inpatient service are what I would call these low-risk ones, which account for about 50 to 55% of PEs. They're the normotensive patients with no signs of RV strain, and they actually do very well with pretty low mortality, and those are the ones we usually treat with systemic anticoagulation. When you get up into the intermediate risk, which does surprisingly count for about 40% of PEs, those are the ones where you have normotensive but RV strain present, whether that be by imaging or by troponin values. Those have reported mortalities as high as 20% when you get into the intermediate risk category. And then the less common but high-risk PE, the massive one, are the ones that have hypotension, they end up on pressors, intubated, have signs of shock. That's only about 5% of total PEs, but they have a pretty high mortality associated with them, up as high as 50% reported. And so we'll talk briefly about anticoagulation management, which I think we're all pretty familiar with, and then a couple special populations that you have to think a little more about your anticoagulant choice. Obviously, the first thing you think about for PE management is whether it's provoked or unprovoked, and some of the things you want to tease out in a history on a patient to determine whether a PE is provoked or unprovoked. Things like recent surgery, hospitalization or immobility, pregnancy and C-sections, whether they're on any estrogen therapy for birth control or other reasons. History of malignancy, and then some of the ones that we don't think about as much, things like inflammatory bowel disease, inherited thrombophilias are provoking factors. And I did see chronic heart failure also listed as well as a potential provoking factor. And then that kind of helps guide you into your treatment duration. For provoked PE, it's 3 to 6 months of anticoagulation therapy, and unprovoked should be indefinite. So when we get into these special populations, for malignancy, Lovenox or low molecular weight heparin kind of remains the preferred regimen of choice I saw in guidelines, but there is some new data coming out recently for DOACs in the malignancy population, and that all got summarized pretty recently just this year in a meta-analysis that came out and looked at 14 different trials trying DOACs in the malignancy PE population. And they found that, with greater than 4,600 patients included total, the DOACs, particularly edoxapan and Xarelto, were more effective at preventing recurrent thromboembolism, with a number needed to treat of 24 than low molecular weight heparin itself. This did come, as it tends to with these anticoagulation trials, at a higher risk of major bleeding than the low molecular weight heparin, with a number needed to harm of 34. And the majority of bleeding that they saw was GI related in these patients, but there was no mortality difference. So there is some data coming out now and a good summarization of it here that shows that DOACs may be a viable option as well in the malignancy PE population. Pregnancy, heparins remain the preferred anticoagulant of choice as they don't cross the placenta. Low molecular weight heparin is generally preferred because it's less monitoring required for the patient. But around 36 or 37 weeks, that low molecular weight heparin, most OB-GYNs will actually switch it back to unfractionated heparin because it can be reversed during delivery if needed. Coumadin, again, is strongly avoided because it's teratogenic, and there is no data for really or against DOAC, so they are just avoided in that population. In the postpartum period, if a woman is breastfeeding, Coumadin, low molecular weight heparin, and fondaparinux are approved. DOACs, again, are not really investigated in the breastfeeding population. For patients with a history of HIT or heparin-induced thrombocytopenia, I think as we know, heparin is obviously to be absolutely avoided, and argatroban is the choice anticoagulant for these patients. And the last kind of special populations we'll talk about are the inherited thrombophilias. The takeaway is that for most of them, DOACs are actually reasonable and approved for use in these populations, specifically factor V Leiden, prothrombin, protein S and C deficiency, and antithrombin deficiency. There was a note that with protein C deficiency, warfarin actually has a higher rate of warfarin-induced skin necrosis occurring, and so actually in those populations, you probably actually should be leaning towards a DOAC as your anticoagulant of choice. And for antithrombin deficiency, if a patient has a severe pulmonary embolism and they're not doing well, it's actually reasonable to call your local hematologist and ask about thrombin supplementation, because that can actually be very helpful for those patients as well in acute kind of periods. Antiphospholipid syndrome was the one that was different. For that one, you're supposed to do a low molecular weight heparin bridge to Coumadin, and DOACs actually are not approved for use in the antiphospholipid syndrome patients. So important to tease out risk factors in a patient's history. If you had a young female with multiple miscarriages in her past, and maybe on the safer side to just treat them with Coumadin until that's sorted out. So now we'll get into the submassive and massive PE population. So the AHA does have a definition to kind of differentiate these two from each other. Massive PE they define as an acute pulmonary embolism with sustained hypotension of a systolic less than 90 for 15 minutes or requiring inotrope support, pulselessness or profound bradycardia with a heart rate less than 40 and signs of shock. They call a submassive PE an acute PE without any hypotension present, but with RV dysfunction or myocardial necrosis. And so from that, the question becomes, well, what do we call RV dysfunction or myocardial necrosis? Well, they define those pretty well for us, too. The dysfunction component is defined by the RV to LV ratio size on echo or CT, and if it's essentially 1, meaning they're essentially equal in size, or the RV's bigger, then you have RV dysfunction, meeting their kind of criteria here. Systolic dysfunction seen on echo as well meets the criteria, and elevated BNP or NT-proBNP contributes to RV dysfunction. And then the other one is EKG changes can actually be indicative of RV dysfunction as well. That can be a complete or incomplete right bundle branch block, anteroseptal ST changes, or anteroseptal T-wave inversions. And when you're talking about RV necrosis markers, those are the signs that come from your troponins, essentially. A troponin I above 0.4 or troponin T above 0.1 kind of contribute the definition of RV necrosis to help define this kind of submassive population. So then we'll say, what is the role of the at least systemic lytics in submassive PE? Well, the guidelines do give it a 2B recommendation with a level of evidence C saying that for patients with submassive acute PE, fibrinolysis may be considered as long as there is low risk of bleeding complications being present. And where that comes from is there are a couple different data registries that have tracked the outcomes of PE patients, with the 4 listed up here: MAPIT, ICOPER, REAT, and EMPEROR database kind of being the 4 biggest ones. And when you look at these groups, the incidence of submassive PE range from 3 to about 14.5% in these patients. 30-day mortality in patients who were normotensive is actually very low when they were just treated with systemic anticoagulation, and it was 0.9% in the EMPEROR database, for example. And then overall, it appears to kind of be less than 3%, suggesting a small potential for mortality benefit for the group of for lytics. And the AHA actually said in their guidelines, because these groups actually don't really have a lot of potential for mortality benefit from systemic lytics, the focus on research figuring out kind of where their role should be focusing on more secondary outcomes, things like preventing CTEPH, preventing RV dysfunction, improving quality of life, and functional capacity as well. So this is one of the tables that they kind of cite in those guidelines. This is pooled data and studies that reported right ventricular pressure measurements several months after PE. I will say, if you look at the sample sizes, for the most part, these trials were actually pretty small. The biggest one was that third line down, the Klein trial, who had 162 patients total. But the big takeaway I think that they saw from this is in this kind of percent change column. When you look at the heparin group versus the lytics group, the lytics group had a much bigger improvement in their right-sided pressures, essentially double in terms of percent change from the patients who just received anticoagulation alone. From that, there does seem to be some evidence that, at least from a pressure hemodynamic standpoint, that the lytics actually are improved or better over systemic heparin itself. And if we look closer at that Klein study that had the largest population, this is one of their interesting tables or figures that they reported. And so what this is it's a plot. Basically, on the left, we have the patients who got lytics. On the right, we have the patients who got heparin, and each line represents a patient. And on the left, you kind of have their pre-treatment pressures, and at follow-up for this study was 6 months, you have their pressures kind of down the line. And as we see, overall, for everybody with lytics improved in terms of their pulmonary pressures or right ventricular pressures at follow-up. When you look at the heparin group, overall they tended to do better or at least improve their pressures. But if you look here at these lines that they demarcated in red, actually patients who had an increase in their pulmonary pressures at follow-up, it wasn't exactly a small percentage. There was about 25% of the patients who were treated with heparin alone whose pressures actually went up at 6 months follow-up compared to when they were initially diagnosed with their PE. So they instead said, let's look at some kind of quality or functional outcomes as well, because as the AHA says, that's going to be where the most potential is likely for the lytx population. And so here on the right, we have the lytx group, and then on the left, we have the heparin-only group. And we have a combination of outcomes here, 6-minute walk test, NYHA class. And what you will notice is if you were to look at patients who were NYHA 1 or 2, it actually is pretty similar. It's 82% in the heparin-only group and 83% in the lytx group. And if you look at patients who have impaired 6-minute walk tests or higher NYHA class at follow-up, it actually is pretty similar at follow-up as well. And so from this, you may say, well, you know, the heparin-only group, 75% of them got their pressures better, and they don't seem to have that different in terms of functional outcomes here. So how could you, or what argument would you make for the systemic lytx group? And I will say, but in a sub-analysis, if you look at the patients who were treated with heparin only, 47% of them either got worse or still had persistently elevated pressures at follow-up. So 25% got worse overall, and if you include that plus patients who just didn't get better, it was about 47% of patients who were treated with heparin didn't really have a great improvement in their pulmonary pressures. And if you did a sub-analysis, which they did looking at this group compared to lytx who just didn't get improvement or got worse in their pressures, 46% of the patients who didn't get better or got worse with heparin alone had dyspnea at rest and a decreased exercise tolerance at follow-up. And this was only compared to 28% of patients who were treated with lytx. And that's even despite the patients who were treated with lytx having worse or higher, more severe PEs markers at their baseline. So this suggests that there is kind of a subset of patients that needs to be teased out and investigated to try to figure out there is a group of patients who aren't going to get better or who may actually get worse if you treat them with just systemic heparin and standard anticoagulation. And trying to identify who this group is I think, going to be one of the big things that is going to help us try to figure out who deserves those more advanced therapies or who's going to benefit most from those more advanced things, because 46% versus 28, not from a functional standpoint, not doing well at follow-up is pretty significant as well. And that kind of led to this trial, the PIETHO trial, that looked at fibrinolysis in patients who had intermediate risk PEs. Published in 2014, it was a randomized placebo-controlled multinational trial that looked at systemic lytx for submassive PE. And one of the big things about this trial that's different than the other ones before, I think, is the overall quality of it. It was very large, over 1,000 patients, whereas you saw in those prior trials, there was, you know, some as small as 10 to 20 patients. It was randomized, placebo-controlled, multinational, multi-center. So the overall just quality of this trial was better than a lot of the ones that were kind of done before it. And I think that's why this data is a lot more robust. And what they looked at as a primary outcome was death or hemodynamic decompensation within 7 days. And then they also followed up on 30-day mortality in this study. And then they looked at a safety outcome as bleeding, both major and minor, as well as stroke that was both ischemic or hemorrhagic in nature. And what we see here is their major kind of outcomes table. And I highlighted in red the ones that I think were kind of the big take-homes from this one. In terms of their primary outcome, there was a statistically significant improvement in patients treated with systemic lytx compared to just heparin alone. 2.6% of patients with heparin with systemic lytx versus 5.6% with placebo, meeting that criteria of death or hemodynamic decompensation. But if you look closer, because it's a composite endpoint at where that kind of came from, if you look at the actual death at 7 days from those groups, it actually wasn't very different. A lot of that positivity from that combined endpoint was actually driven by the hemodynamic decompensation, where the rate was much higher in the heparin alone group versus the versus the systemic lytx group. If you look at death at 30 days, again, the death endpoint alone remained not significant. So I think the takeaway from this is that while, again, no large mortality benefit, but as you know, the AHA says in their guidelines, that's really not the best marker in this subgroup. But in terms of other things like hemodynamic decompensation requiring pressors, requiring intubation, that there was actually improvement from the systemic lytx group here compared to the heparin alone group.
Those people So they basically went from, they got lytics early versus hemodynamically decompensated, then they get lytics late, and then there wasn't a difference. Right, so it's like at time 0 versus at time decompensation. We can talk about it.
Okay.
So essentially, the group that decompensated, though, the argument is.
Oh, that they ended up getting
They
lytics.
basically dropped their pressure, and then they had to get lytics.
Yeah.
So they got the treatment that the other group got. So it's almost like a preventive lytics versus
Yeah.
a reactive lytics.
Exactly.
There wasn't a signal in the other outcomes.
Yeah, so that's like the death in and of itself not being positive between the two groups. Yeah, the lytics from the hemodynamic standpoint, whether you give them up front and helping prevent that decompensation, yes. So if you look at their kind of safety data, you look at the bleeding outcomes between the two. They're in, like I said, as does come with a lot of these anticoagulation trials, there was a trade-off with this between bleeding down the line. Major extracranial bleeding and mostly hemorrhagic stroke actually was higher in the lytics group than the heparin-only group as well. So then we'll get to talking about what is the role of catheter-directed lytics. There's two kind of big trials that have looked at catheter-directed lytics versus the ULTIMATE trial, and the other one we'll talk about in a minute is the Seattle 2 trial. The ULTIMATE trial was a randomized controlled trial of, again, only 59 patients, but they had submassive PE and were randomized into standard anticoagulation therapy versus the ultrasound-assisted catheter-directed lytics and anticoagulation, which is that standard ecosystem that we see used a lot in the CCUs. At 24 hours, patients treated with catheter-directed lytics, they had higher rates of improvement in pretty much all of their echo-associated outcomes, which was their RV to LV ratio, RV systolic function, their TAPC, their pressure gradient, and the IVC diameter. But if you follow these patients a little longer term, at 90 days, heparin alone did tend to catch up in a lot of those categories. The only one that remained significant at 90 days was the RV systolic function, which remained much more improved in the catheter-directed lytics group compared to the heparin alone group. Again, invasive hemodynamic measurements could only really be done in the lytics group. The patients who just got systemic heparin or standard anticoagulation didn't get invasive hemodynamics, but in the catheter-directed lytics group, there was a significant improvement in the systolic and mean PA pressures as well. As we saw in a lot of other trials, there was no mortality difference between the two groups and no difference in major bleeding or adverse outcomes, at least with the catheter-directed lytics in this trial. And so this is kind of a busy table, but it's their major outcomes one. And I think the big bottom line is the red boxes, which report the p-values. On the left, what we're reporting here are a lot of these echo outcomes that they looked at: RV to LV size ratio, RV systolic dysfunction, TAPC, pressure gradients, and the IVC measurement. And the big ones, I think, are here kind of towards the right, the difference at 24 hours and the difference at 90 days. And as I said before, what this kind of summarizes is in 24 hours, these patients who got catheter-directed lytics actually had much more improvement in all of these parameters compared to the group who got heparin alone. But if you follow them out towards 90 days, the heparin did tend to catch up in a lot of these categories, with the one that remained improved being the RV systolic dysfunction being improved in the catheter-directed lytics group compared to the heparin alone. And so this is the invasive hemodynamics from these patients. And again, these were only available on patients who got catheter-directed lytics because they didn't do right heart caths on the patients who just got heparin alone. And as you see, it's kind of what we expect, all statistically significant improvements in hemodynamics. The big one, or the one that I thought was most interesting, was the cardiac index. At baseline, the patients had an index around 2.5, which isn't horrible, but it's not very good at all at that point. And just within 24 hours, they're able to raise it up to almost 4, essentially, just with the catheter-directed lytics alone. Now, what the heparin group would have done on itself, obviously, we can't really extrapolate or say. And then we get to the Seattle 2 trial, which is the two bigger ones that are talked about, at least with catheter-directed lytics. It's a prospective, single-arm, multi-center trial. So again, it's a little different than the ULTIMATE trial in terms of its setup. It did have more patients at 150 who had acute PE, and this one was a mix, actually, of massive and submassive, but there was a lot more submassive kind of represented in this group. And they were treated with, again, the ultrasound-assisted catheter-directed lytics, which is the ecosystem that we use. And then they were followed up at 48 hours for this one. Again, they saw that the RV to LV size ratio significantly improved at follow-up, coming down from 1.5 to 1.1 just within 48 hours. And then the mean PA systolic pressures also had a pretty big decrease as well at follow-up, going from about 51 down to about 37. just within 48 hours with no intracranial bleed complications that they noted. And this is kind of their figure and data table that summarizes their kind of efficacy and safety outcomes. So on the left, you see, the improvement in the RV to LV ratio diameter at follow-up, and that their pressure is also significantly improved. Even by the end of the procedure itself, you actually saw a pretty big improvement in the catheter-directed lytics group compared to the, well, there was no comparison group in this study because it's a single arm. And if you look at their safety outcomes, again, the big one that they kind of touted in this one was that the intracranial hemorrhage or bleeding rate was 0. So it did come with a pretty big or pretty significant safety profile as well from the catheter-directed lytics group.
Quick question. Do you know offhand the amount of lytics someone get when they get catheter-directed lytics versus systemic lytics? What the percentage, like how much less lytics do they get when it's catheter-directed versus systemic? Do you have a sense?
In terms of like the percentage less dose, I actually don't know off the top of my head between the two.
So full dose lytics is 100, and the catheter-directed lytics is usually 1 per hour.
Yeah, so 24.
So it's substantially less. So it's about a fourth over an 18-hour period, as opposed to
An hour or two.
Within an hour or two. The half dose, the other major approach that's been compared for submassive is, after Pytho, nobody does full dose lytics, but half dose lytics is the other, which would be 50. So those are the sort of 3 options. How much lytics you get does depend on whether you got 2 catheters or one side or the other.
And then so moving from there towards the mechanical thrombectomy side of things, which is one of the newer interventional techniques that are being tried for submassive PE. This was a data table I found that kind of summarized a combination of what the different techniques different companies or people have come up with are, and kind of what they have tried so far in terms of proving their efficacy. And the takeaway is that one, in terms of the size of things done so far, it's very small. A couple of these are just 1, 4, 9 patients. And a lot of the outcomes are not very robust in terms of proving. They're really more proof of concept. It's things like patient has significant clot resolution, improvement in pulmonary artery pressure, but not a lot in terms of proving kind of clinical outcomes yet. And that's because this is a more relatively new technique. But these tend to be more smaller proof of concept trials so far for the mechanical thrombectomy. But at least recently, that takes us kind of to the Flair trial, which just came out a little bit earlier this year. And that was a prospective trial evaluating the safety and efficacy of the FlowTriever system for a submassive PE. And they kind of defined submassive, at least in this trial, based on that echo definition of the RV to LV size ratio of them being essentially equal or bigger in size. So they had 106 patients, which compared to a lot of the other ones, it's not robust by any means, but it's the biggest one so far. 106 patients kind of proving that the system can work. They treated patients with the FlowTriever, and they saw basically there was a significant decrease in the RV to LV size ratio. And I don't know exactly how they determined this, but they determined what would be the estimated improvement with heparin in the timeline that they were doing, and showed that the improvement in size was bigger with the FlowTriever system than heparin alone. Again, I don't know how they determined that estimate, but patients who had elevated pressures with the FlowTriever system also experienced a significant decrease in the pressure compared to the heparin alone, and only one major bleeding event was reported. And so this kind of summarizes that kind of efficacy of the FlowTriever system. They have the pre-procedure RV to LV ratio size here on the left, and they have the 48-hour RV to LV ratio on the right over here. And you see there is at least a significant drop with the mechanical thrombectomy system. And again, this dotted line, I don't know how they determined this, but they showed that this was the drop that they thought was expected with heparin alone, and that they thought that this was an improvement over that. And then again, when you look here at the patients who had pulmonary hypertension or elevated pressures when they went to the cath lab to have the thrombectomy done, there was a significant decrease in the pressures. But when you look at patients who did not have pulmonary hypertension, there was not a difference. But again, if they didn't have elevated pressures, you wouldn't really expect there's a lot of room for improvement anyway. And from that, at least the CHEST guidelines do comment on the role of mechanical thrombectomy, and it's kind of down here, this bullet point 25. They say that in patients who have acute PE associated with hypotension, who have a high bleeding risk, and they've either failed systemic lytics or have shock that is likely to cause death before lytics can be done, if you have appropriate expertise at your hospital, they do suggest catheter-assisted thrombus removal over no such intervention, essentially. Now, and if you're going to go to the cath lab anyway and do systemic lytics, I don't know what timeline you would say this is quicker than doing, catheter-directed therapies as well, but they do at least have a comment on the role of mechanical thrombectomy in their guidelines. So we'll go then kind of working up from submassive PE to the massive PE population. In terms of massive PE, it does, in terms of systemic lytics, there is a 2A recommendation for systemic lytics saying fibrinolysis is reasonable for patients who have a massive PE and acceptable risk of bleeding complications. And so looking at kind of where that comes from, the takeaway that I found going through this is that there's a lot of very messy data on the massive PE population, and there's been some work done to try to clean it up. And what I mean by that is that there's 13 randomized control trials looking at the effects of lytics in the massive PE population thus far. But there's a lot of heterogeneity between those two studies, and an example of that I kind of put up here is that of those 13 studies, 6 use alteplase, whereas 4 use streptokinase, and 3 used another lytic. If you look at the 6 that use alteplase, 2 did a bolus infusion, 4 did an IV drip over a couple hours. If you look at the ones that did an IV drip, 3 of them used heparin at the same time as the lytics, 1 didn't. So from that, that's just an example of that there's a lot of heterogeneity in the treatment profiles between these groups that kind of, I think, makes drawing conclusions from it a little more difficult. But here is some of the summary of kind of those pressures that patients had pre and post lytics, and this is just in a couple hours after systemic lytics for massive PE. And again, I think the big takeaway here is the columns on the right, the lytic group here and the placebo group here, and what you see, and placebo meaning heparin essentially. And what you see is in the heparin group, at least acutely in, I think, a couple hours, which is a good endpoint in patients who have massive PE because they have hypotension and shock, so hours is a timeline that you're dealing with there. Heparin really didn't do a whole lot to improve pressures kind of acutely, whereas the systemic lytics pretty much across the board in these different trials had a pretty immediate improvement in the pulmonary pressures that these patients had. So again, in a pretty quick timeline in a population that's pretty sick, the systemic lytics actually did at least show to have a pretty robust improvement in pulmonary pressures quickly compared to heparin alone. And so this meta-analysis paper came out that tried to kind of clean up some of the heterogeneity here and kind of had inclusion criteria where they said they're only going to look at patients who got systemic lytics for just massive PE. And again, some of those other studies was a combination of submassive and massive. And so trying to just include ones that were relatively similar to try to extrapolate a meaningful outcome, this meta-analysis determined that systemic lytics actually did have a mortality benefit in massive pulmonary embolism, and they had a number needed to treat of 10 in order to prevent a recurrent VTE or death. There was no difference in major bleeding between the two groups, but again, as we see in a lot of these anticoagulation trials, there was a difference in non-major bleeding between, with a number needed to harm of 8 for the systemic lytics alone. And then so we'll move on there to talk about kind of surgical embolectomy as one of the other options that's kind of in the treatment arsenal for patients with massive PE. It's kind of found a place as a second-line therapy in patients who have a massive PE who have a contraindication to lytics or who are still in shock, essentially, despite lytics being given. And the reason it was kind of a second-line therapy is if you look at older case series, it had a pretty high mortality associated with it, with 20 to 30% procedural mortality being reported in older case series. But there was a more recent study that came out from the Mayo Clinic that showed that they used kind of a PE response model, or a PE response team model. And by doing so, they try to identify patients early on who weren't doing well, or patients earlier on who were going to need more aggressive intervention. I think with the argument being that in a lot of those case series that had mortalities of 20, 30%, in a lot of those patients, the embolectomy was more or less a salvage operation. A lot of those patients had already suffered a cardiac arrest and were very, very sick beforehand. And they argued that if we identify patients earlier who are going to need this, it may have improved outcomes. And they did show that actually they had a operative survival rate of 94% in their group and a 1-year survival of 86%. And this suggests that the higher mortality may have been due to kind of delayed intervention and not recognizing earlier on enough the patients who weren't doing well and who were going to need more aggressive therapies. And so trying to identify those patients early on and sending patients earlier rather than later to surgery may be kind of where this procedure needs to find its place in the treatment algorithm. Now, extraction for pulmonary embolectomy is limited to the visible pulmonary arteries. So if a person is not doing well, but they have kind of showered, very distal, diffuse clot burden, it may not be a viable procedure for them. It needs to be in an area where the surgeons can actually get to it. And so we'll start kind of looking down the line now at more kind of long-term complications and outcomes from patients who have had pulmonary embolisms. So this is a case of a 72-year-old male who had a history of 3 prior PEs on permanent anticoagulation. And he's had chronic 1-block dyspnea exertion and shortness of breath that over the past several weeks, he says, has gotten a little bit worse to the point that he's just not able to get done what he needs to get done at home. When you see him in clinic, his CVP is elevated and he's got bilateral edema, but he has no orthopnea, he has no crackles, and from a left-sided standpoint, he sounds like he's doing pretty well. So you get an echo on him, and here's what you see, and his RV is essentially humongous at this point and not doing very well from a functional standpoint. And again, with a dilated IVC that's not moving, his right-sided pressures are in the 50s and kind of have been that way presumably for years at this point. And so that brings us to talking about CTEPH as one of the long-term complications that you're trying to prevent in treating pulmonary embolism. It has a reported incidence of about 3 to 4% following PE, and the largest database was this U.S. Healthcare Cost and Utilization Project that found a follow-up rate of about 3 to 4% in patients who will ultimately develop CTEPH. And I thought this was actually pretty interesting, but the guidelines from the AHA that talk about it acknowledge that about 63% of people who ultimately are diagnosed with CTEPH actually never got diagnosed with their initial PE. And so this leads to the assumption that the true rate of CTEPH developing is probably not entirely well known either. And there was a prospective study that kind of looked at determining after a PE, how long after that can you kind of begin to see how the RV is going to look and the right-sided pressures are going to be in the long term. And this study showed that after about 38 days post-treatment is kind of where the RV pressures and function tended to plateau and not really improve a whole lot after that. And from that, they kind of concluded or suggested that around 6 to 8 weeks after you start your PE treatment, it would be reasonable to think about getting an echo in the patients and follow-up just to kind of see how things are looking, because however the RV looks or the right-sided system looks at that timeline is probably going to be similar to how it's going to look in the long run as well. And so we'll talk for a minute about the different types of CTEPH classification. There are 4 different types of CTEPH in terms of location of disease, and it affects kind of how you think about managing it down the line. This type 1 pulmonary occlusive disease, it represents about 25% of cases, and it's kind of fresh thrombus with some, you see some fibrin mixed in as well. And it's in either the main or the lobar pulmonary artery, so very proximal location in terms of where it is in the pulmonary arteries. Type 2 disease accounts for about 40% of cases, and it's characterized more by intimal thickening with or without thrombus present in the main to segmental pulmonary arteries. So is where this first type actually had, kind of fresh thrombus and kind of the lumen itself. This one is more kind of a disease of the blood vessels with intimal thickening being seen as well, and still fairly proximal in the main to segmental pulmonary arteries. As you get out towards a type 3 CTEPH kind of picture, you get about 30% of cases. This is characterized by fibrosis and intimal webbing of the more distal segmental to subsegmental arteries. And then type 4 is kind of the last one, where you have less than 5% of cases looking like this. It's kind of in the distal capillary beds, and it's a capillary level vasculopathy. It's inoperable because of that. You can't operate at the level of the capillaries, and it behaves more like a WHO class 1 pulmonary hypertension pattern. So in terms of factors that predispose someone to developing CTEPH after their initial PE, things like younger age, patients who have had multiple episodes of PE, and if they have larger perfusion defects seen, those are kind of the risk factors, which I don't think are very surprising risk factors for the development of CTEPH down the line. But it is also seen at an incidence of 2 to 1 in women compared to men, and in some other registries and databases, it's much more commonly seen in Japanese patients. suggesting that there's also, on top of the characteristics of the PE, a role of gender, race, environmental exposure. A lot of other things can help affect or influence your risk of developing CTEPH down the line. And it's also seen at a much higher incidence in patients who have any of the inherited thrombophilias. The most one by far is the lupus anticoagulant and antiphospholipid syndrome, where 10 to 20% of patients who have PEs in that population will ultimately end up developing CTEPH. So if your patient comes in and you're worried about this, how do you go about working it up and getting them the formal diagnosis? Well, the diagnostic criteria to classify someone as having CTEPH is actually pretty straightforward. The first is that they have to have pulmonary hypertension, which is defined by right heart catheterization. It's a pulmonary vascular resistance above 3 Wood units with a PA systolic above 40 and a PA mean above 25, so elevated pressures with high resistance in the pulmonary system. The next thing you have to establish is that they have a persistent perfusion defect, and the way to do that is with the Q scan, and they have to be on anticoagulation therapy for at least 3 months before you get that scan. A VQ scan is more sensitive than a CTPE for long-term clot visualization or defect visualization, and so it's the preferred imaging modality over doing a repeat CTE down the line as well. And then the last step is to exclude other etiologies of pulmonary hypertension. So, when you get that right heart cath, make sure that their wedge is normal and that the left-sided system is looking like it's working fine, and then PFTs to evaluate, make sure this isn't a consequence of longstanding COPD or something like that. So once you've diagnosed your patient with CTEPH from their multiple prior PEs, you got to think about what are we going to do for this person. To date, CTEPH remains a surgical disease in terms of its treatment. There was a review of 1,100 patients who underwent pulmonary endarterectomy at UCSD, which remains, I think, the highest volume center in terms of doing this procedure. And what this table is they broke patients up in terms of their type of CTEPH, whether it was that proximal type 1 or that type 2, all the way out to the capillary bed level type 4. And they looked at the top row in each of these is their pre-surgical, and the bottom row is their post-surgical kind of measurements for resistance, cardiac output, which I thought were 2 of the more interesting ones, and then systolic and mean pressure and mortality. And what you see, not surprisingly, is that at least for these more proximal types, there's a really fantastic outcome in terms of improving their pulmonary pressures and increasing their cardiac output from where it used to be. They reported pulmonary resistance in dynes, but 270 is pretty close. It's only very mildly above 3 Woods units, so there was a pretty good improvement, at least in the more proximal types of CTEPH. As you get up more distally, as you would expect, the outcomes weren't as good because the location of the clot or the location of the lesions were just kind of more distal, more difficult to access, and as they get more distal, it's more areas that you need to be working on. In terms of functional outcomes in these patients, this was actually very interesting. If you look at the patients who kind of went to UCSD in this study to have a pulmonary endarterectomy done, 91% of them had NYHA class 3 to 4 symptoms before the surgery started. And if you followed them out to 1-year follow-up, 91% of them were then class 1 to 2. So from a functional standpoint, they actually did really, really well in terms of improving their functional outcomes with the surgical and embolectomy. The RV geometry actually improved towards normal after this. Dilation regressed, hypertrophy improved. The RV actually began to look a lot better once that pressure was relieved. And the tricuspid valve, even though a lot of them had bad TR due to elevated pressures, the function rapidly improved following the procedure, and in very few instances did they actually have to intervene on the tricuspid valve during this procedure. In terms of adverse events from the procedure, mortality was about 2.5% reported at UCSD over a 3-year period, and they said that this indicates a much improvement in prior reported mortalities, suggesting that improvement in technique and familiarization with the procedure itself play a pretty big role in determining this. Reperfusion pulmonary edema is one of the things that can happen kind of on the sooner side after this procedure. It happened in about 5 to 15% of patients, and if needed, this was treated with ventilation, but diuresis was kind of the mainstay in treatment for this reperfusion pulmonary edema. And then the other thing is reperfusion pulmonary hemorrhage, which occurred in 3.8% of patients, and they didn't say exactly how many, but they said some of which required surgical re-exploration for that pulmonary hemorrhage that occurred from that revascularization of the pulmonary system. So we'll turn now to look briefly at catheter-based interventions, which are emerging as a potential technique for CTEPH treatment as well. Balloon pulmonary angioplasty is accepted as an alternative treatment for CTEPH. It has a 2B recommendation in the ESC guidelines for patients who have surgically inoperable disease or patients who have persistent disease following surgery. They do say that when you're determining who you're going to send for this or who you're going to think about doing a balloon pulmonary angioplasty on, there is some kind of guidance in terms of technique for how to think about it. They do say that when you're thinking about lesions you see and which ones to go after, they should be guided by VQ scanning. So you should only be looking at parts of the lung that do have a perfusion defect seen, so that you can target kind of the highest risk lesions and leave the lower risk ones towards down the line if you need to. And they do say that if you see a lesion that's either a CTO or a blind pouch, they recommend leaving them alone because the distal anatomy is unknown and you kind of won't know what you'll be getting into as you go further beyond those. But once you have decided that the patient isn't a great risk, a candidate for surgical embolectomy kind of down the line or pulmonary endarterectomy, this can be done over multiple sessions. From a safety standpoint, it's mostly recommended that you just kind of limit your contrast and radiation dose for each session. They say there's no harm in getting done what you can and then bringing them back for future sessions if need be. The goal of this is to establish what they call grade 3, which is normal pulmonary flow, and then with a pressure wire, look at the drop across the lesion after treatment. And you want the pressure ratio to be above 0.8, signifying that you've actually kind of really limited the hemodynamic effects of that lesion after you've dilated or opened it back up to not cause significant obstruction at that point. And while you want to open it up as much as possible to kind of decrease that pressure ratio, they do also say that you don't want the pressure distal to the lesion after to be above 35 millimeters of mercury, because if this happens, reperfusion pulmonary edema is pretty high risk in that part of the lung that lesion's going to. In terms of following these patients up after they've gotten balloon pulmonary angioplasty, they say that the goals are essentially should be resolution of pressures as well as symptoms. And if a patient is on pulmonary hypertension medications, you should start trying to get the patients off of those medications once they've had this procedure done, because if they're asymptomatic on those medications, they argue the goal should be to get somebody asymptomatic off meds. So you should start about trying to think about taking those off, and if they develop symptoms despite that, maybe that means they need to go back and have some of those other lesions that they have investigated for angioplasty if need be. And just in terms of the outcomes or efficacy of this kind of emerging treatment option, there was a multi-center data registry in Japan that showed very, very good procedural outcomes with this, and that they were able to maintain mean pulmonary pressures less than 25, generally for longer than 3.5 years. So pretty decent in terms of duration of the effect of the treatment as well. In terms of medical therapy for CTEPH, it's extremely limited. It hasn't really been shown from a medication standpoint to have very good outcomes or improvement, at least in patient quality and functional capacity. The one that I saw cited the most was this example of the BENEFIT trial, which looked at bosentan therapy for patients with CTEPH who had inoperable disease or residual disease after an embolectomy. They had 157 patients and put the patients on bosentan for 16 weeks, and they saw that there was no improvement in exercise capacity or a 6-minute walk test. There was a mild reduction in pulmonary vascular resistance, although again, they didn't really have any good functional improvement, and that the resistance drop they saw was much, much less than you would expect to see with surgical intervention. And so that's an example of kind of how this remains kind of a procedural or surgical-based process that has to get fixed. So we'll go back to kind of those first couple cases I talked about in the beginning, case 1 follow-up. So this patient was treated with 18 hours of catheter-directed lytics, 2 catheters, 0.5 milligrams per hour TPA through each one, because they had that clot burden that was kind of on both sides. So they had one going towards each pulmonary artery. The mean PA pressure decreased from 35 to 21 within 24 hours. His RA pressure came down from 18 to 5 over the course of those, or 18 hours, over the course of those 18 hours. And his PA sat increased from 51 to 73.4 just in 18 hours, which is consistent with a lot of the data that we talked about, showing that it has a much more rapid and kind of quick improvement. His catheters were removed. He was transitioned to Lovenox initially because we weren't sure if this was classified as a malignancy-associated PE, because he had only been 3 months out from his B-cell lymphoma treatment. But hematology actually said they were comfortable and wanted him to go on long-term anticoagulation with the DOAC, given some of that more recent data that had come out. So he actually went home on dabigatran. In terms of case 2 follow-up, this is the patient the 30-year-old who had a recent pelvic fracture and a lot of immobility with, her heart rate's in the 130s and a pretty large clot burden. She was considered to be high risk for any lytics because she just had that very recent car crash and known left pelvic fracture, and so she went for actually one of the mechanical thrombectomies, catheter-based mechanical thrombectomy. So she underwent a bilateral successful catheter-based mechanical thrombectomy of the right and left pulmonary arteries. In terms of her pressures in the cath lab, her mean came down from 35 to 25 by the end of the procedure, and her PA sat improved from 47 to 57 by the end of the procedure. The next day, her RV to LV ratio size had improved as well, and she was ultimately transitioned to Xarelto. And for that case, this is an example. This is the pulmonary angiogram of what they saw in this patient. This is the right pulmonary system where she had a very, very heavy clot burden right at the bifurcation of the main right pulmonary artery into its lobar branches. After mechanical thrombectomy, this is what they were able to pull out with that. They used that flow retriever system that we talked about in the Flair trial, and they were able to pull out a pretty large, extensive clot burden from her. And as I said, get those kind of hemodynamic improvements more robustly and kind of quicker for her. And then following this large kind of what looks like very fresh looking clot burden coming out, her repeat pulmonary angiogram showed a pretty quick and significant improvement in flow to that right lung. So I'll take the last minute or two just to talk about kind of what we use here at Emory is the Emory algorithm for massive PE and submassive PE. So for massive PE, the first kind of question we think about is, does this patient have a thrombus in transit or an intracardiac thrombus present as well? And if they do, then that becomes a surgery or catheter embolectomy that needs to happen because resolution of that catheter in transit or getting that out is going to be an important part of that patient's treatment plan as well. If they don't have that, the first question, as we see now, is does this patient have a contraindication to lytics? If they don't, then we do systemic lytics, TPA, 100 milligrams over 2 hours. And if they have what we call a relative contraindication to lytics, then they can go to the cath lab for catheter-directed therapies as well. Talking about how we kind of think about or manage the submassive PEs here. For the low-risk population, they're pretty much treated with low molecular weight heparin. The medium risk, for the most part, is treated with heparin as well, and consideration of an IVC filter if they need one, and they need to be monitored to make sure they don't progress to one of the more massive or higher risk PEs despite that standard therapy. If they have a high-risk submassive PE, which again, we think about patients who have troponins above 0.1, high D dimers, EKG changes, or clinical signs that they're just not doing well, what we get to is kind of this high-risk submassive PE algorithm that we usually try to think about here. And with that, we think about the location of the PE and are they a surgical candidate. If they have a proximal PE and are a good surgical candidate, we think about sending these patients to surgery or angiovac thrombectomy. If they are not, then we think, do they have an absolute contraindication to lytics? If they don't, then catheter-directed lytics is kind of the way we think about handling these patients. And if they do have an absolute contraindication to lytics, then they can do high-dose heparin plus minus an IVC filter if they need one for some other reason. So with that, we'll kind of wrap up. Thank you for coming. I want to thank Dr. Jabber for helping me out with making the PowerPoint and kind of going through some of the data and the way we think about doing the managing PEs here at Emory with the PE response team. Yep.
One is, we know for high-risk patients, pregnant patients with mitral valve prosthesis or something, we can use warfarin after the 13th week of pregnancy. Is that the case for patients with PE? Do we differentiate people with massive PE or not, whether they get warfarin or low molecular weight heparin, or we always do low molecular weight heparin regardless?
Yeah, so I know at least for the mechanical valves, we tend to avoid Coumadin in the beginning, but it can be used down the line after development of the fetus, arguing that it's not going to be as teratogenic kind of in the later stages of pregnancy, at least in the AHA guidelines that I saw talking about pregnant patients, that they did recommend heparin at least for the treatment of PE. There wasn't a whole lot of talk about Coumadin other than its teratogenic effects.
And the second question was, any place for hemodynamic support and respiratory support like ECMO in treatment of massive and submassive PD?
Yeah, in terms of the role of ECMO coming down the line, I didn't see a lot in terms of guidelines or recommendations about when to do or use ECMO in these patients, but if a patient, I would say, is not doing well despite aggressive therapies, despite lytx, despite thrombectomy, this is kind of a transient process you think you need to support them to. In terms of the indications to use ECMO, pulmonary embolism is one of the reasons or indications you can use that for if you need to support a patient through some kind of acute period and you think they have a good recovery potential. So it is something you can think about doing as well.
Hey, Bryan, thanks a lot for a great talk, summary of the data. You notice from all the slides that the data is still somehow limited in what therapies we can give for PE. The best data we have is on systemic lytics, but there's a lot of other therapies that we've experimented with, including the ECMO that you mentioned, or other support with RP impella and other things, and catheter therapy and surgery. What we need is a randomized trial for all these things in high-risk patients. The reason we're experimenting with all these treatments is that over the last 30 years, if you look at treatment of pulmonary embolism, really has not changed a lot, and the mortality is still unacceptable, especially for massive PE patients, where mortality is at least 20%. Submassive is about, the PE-related mortality is about 4 to 5%. So that's higher than MI mortality, and we have not done a lot with it. We're trying to work on randomized trials now through the NIH and through companies and things to get things rolling in terms of catheter therapies versus medical therapy or surgical therapy versus medical therapy. I'll take the ECMO question. The ECMO and intubation of patients with PE is very tricky. We're thinking that when patients come with massive PE and you give them systemic lytics, some of them do not do well, and it becomes messy to put them on ECMO. So if we have availability for ECMO immediately on somebody who's getting CPR, I think that would be the best option in patients before we give them systemic lytics. So that's a good therapy that we've seen works. And once you put the patient on ECMO and they stabilize, you can think about what you want to do for them, whether maybe catheter lytics or catheter therapy or surgery, but you first want to stabilize them. Intubating these patients is very tricky because if these patients have a blood pressure that's 100 or 110 with tachycardia and you intubate them, they almost always crash. So you try not to intubate PE patients that look very sick unless you put them on support first. But this is all from experience and from limited registries. We don't have big trials when it comes to that.
The one thing I think, just to at least raise it, because I think it's important. You mentioned the PITHO trial is probably the biggest trial in submassive PE that used full dose lytics. The what's the right way to say it? The heparin lovers or aggressive treatment haters would also cite there's a 2-year follow-up published from that study. And one of the, I think, challenging facts about that was that long-term follow-up didn't show any difference in the patients treated with lytics versus treated with heparin only. So, I think one of the big questions, and you alluded to it, is I think we have to think about these obviously as two very distinct populations of the sort of submassive group and then the sort of massive group. But what the right outcomes are, what the right populations are that are likely to benefit from more aggressive treatment in submassive PE is really hard. From a kind of in the trenches perspective, it's really easy to see the analogy between this, for example, and early stenting for coronary disease, right? You have a therapy that immediately shows a hemodynamic change. You see it you see a picture, you see these beautiful things that you remove the evil humors, right? I mean, it's really nice to see the change, and I think all of us feel like there's clearly a role for aggressive management in the right population of patients. The struggle is just to figure out who it is. And I think in the submassive population, that's a really hard, I think Wissam is absolutely right. We just need to figure out the right way to do a trial that can help to answer these questions, because at this point, we're still trying to figure out who the right people are.
Yeah, and I think a lot of that comes back to the slide from that Klein paper that showed kind of the pressures for patients at follow-up, and even for the submassive people treated with heparin alone, it was like 25% of them actually had higher pressures despite that, and if you look at people who got higher or didn't improve, it was 47%. So how to figure out who those people are, I think, is going to be kind of where these more advanced things will find a place.
Well, and the other thing is what the impact is, right? So, I mean, if you look at, you know, for you, my guess is a 6-minute walk test for you at a year is not a really meaningful assessment of your functional capacity, right? I mean, hopefully you don't measure your functional capacity and how far you can walk in 6 minutes, right? So I think for active people who have, you know, robust lives, we need much more robust functional assessments to get a sense, because our you know, for a lot of people, that's not the right algorithm, especially in a population like that, which has appreciable but relatively speaking sort of lower, you know, major morbidity and mortality.
That's a great point. For when I just take this, it's a great point about when designing trials is what outcome you're looking at, and so far with the submassive PE, they've been looking at mortality and recurrent PE, which is to start with mortality that's not very high, and it might not have been the best question to ask. For massive PE, yes, it's mortality because that's what you want to look for initially. But for the submassive population now, there's a big debate in our community about looking at other endpoints. One of them is cardiopulmonary stress test at 3 to 6 months, and also extensive quality of life questionnaires and things like that would try to differentiate these treatments.
Yeah, and I think I even said in the AHA, they even had in the guidelines for PE, they even had that statement. They said for submassive PE, the mortality is actually pretty low to the point that mortality is not going to be the marker that you need to look for. It's going to be more functional outcomes in those patients that you're going to try to prove the benefit of your therapy.
The preceding program is copyrighted by Emory University.